Welcome, Hamish.
Oh, thanks, Mel, for coming along. I'm happy to chat with you, and we'll talk about whatever you like.
Excellent.
What I'd like to
Mm,
see is these illnesses not be associated with stigma and bias, and that's been
yeah,
a terrible, terrible thing for these
yeah.
patients. That
Mm,
they're somehow blamed for having the illness. I mean, the chronic fatigue
yeah,
people have had a terrible time, and I really
mm,
feel for them that for a long time they weren't
mm,
validated as having a real illness. Well, they
yeah,
clearly do. And they
yeah,
have healthcare costs that are huge. So, so
yeah,
um, I've been really supportive of them to say that yes, this is a legitimate disease and it's not your fault,
yeah.
and yet it was triggered off by something or other. But the bias and stigma that they've had endured has been horrible.
Mm,
So
mm.
I think it's great now. There's treatments for that.
So I know you're now quite familiar with the core principles in the switch, being around chronic illness being related to the stress response, the neurology of the thinking patterns, the beliefs, the lifestyle issues, and the deeper emotion issues from the past. So, what is your opinion on that as a framework?
Well, I've done quite a lot of research in the last 5 years on modern neuroscience. Um, and it seems to me that what you're doing is right in there with modern neurosciences. It's not a surprise to me what you're doing and why you're effective, because I mean, this has been around now. This stuff has been around for about 30 years, especially the last 20 years, last 10 years. It's been starting to translate into clinical practice.
A criticism of NLP and of the switch is that it's all pseudoscience. What's your opinion on that?
Well, yeah. I mean, I think people just have to look at the sciences coming through. I mean, it's all out there. I mean, you just
Mm,
put in modern neuroscience on Google, you get heaps of stuff. And I've done the Google Scholar stuff, and I've looked at the videos, and I've interviewed people, and I've in our research I've been interviewing pain specialists and neurologists and stuff, and people, and there's no pseudoscience about what they're doing. This is what they're
mm,
doing. I mean, it's very solid. And some people take up these ideas early on.
mm.
Uh, so those people who take up the ideas earlier might be called early adopters of a new technology. And I perceive you and some other colleagues that I know to be early adopters. Very hard to set up a randomized controlled trial when someone's already having treatment of another type. It's not that easy, as it
Mm,
turns out, because you've also got, I mean, one way to do it might be that you have people act as their own controls. They have kind of normal treatment for a year or so with their chronic pain or
mm.
something, and then they have the new treatment, and then you see, but it's not that easy, as it turns out. So I think it's simplistic to say there's no evidence. There is lots and lots
Mm.
of very good evidence, um, and really the proofs in the pudding of people starting to get better with a treatment. Well, then you've got to research why that is the case. Why do some people get?
Absolutely.
Hmm. Oh no, I think treatment's valid if it's proving effective. I mean, I wouldn't ever expect any treatment to be 100%. As I said, I just don't think you're not going to get that.
Mm.
Oh yeah, I'm not an expert in translational science, but I know that a lot of the things we do in medicine, firstly, haven't been that well um, scientifically proven prior to being taken up, and then once they're taken up, it's almost unethical not to offer it to them. You see what I mean?
Yeah.
There's a lot of it's
Yeah.
quite complex, really. And in the functional neurological field, you've got some very good neurologists all around the world. John Stone, for example, who I met in 2013, he's sort of the leading person in this. He's basing his treatment on the modern neuroscience and disorders of perception. But the randomized controlled trials in that, there's only half a dozen of them. But
Yeah.
that is now standard practice.
Right.
Standard
That's interesting.
practice. It's really interesting because I've looked,
Mm.
I've dug under the horses and looked in the horse's mouth on this one, And
Mm.
there's not a lot of great research, but that is a standard practice, and people are getting better with it. So you've got to think, well,
Mm.
they're onto something. But that's where the theory, neuroscience theory, is, is
Mm.
way over my head, but
Yeah.
that's where it's going, and that's supported by um, clinical evidence and clinical experience, and eventually we'll
Mm.
get the randomized controlled trials with that. So for me,
Yeah.
Mel, I mean, I'm not so I don't, I'm not hanging around for a randomized controlled trial before I refer someone. I'm saying,
Mm.
is this practitioner effective?
Yeah.
And yes, that's where I'll do the referrals.
So, what sort of people do you think doctors should be referring to the switch?
Oh, anyone with a chronic illness, I think.
Mm.
I don't think it matters too much. I mean, the sort of so historically unexplained symptoms are good ones, but
Mm.
I imagine you'll have some good success with anyone with ongoing symptoms, because
Mm.
even if you have a kind of a structural problem like multiple sclerosis or whatever, there's a structural problem there, you've still got to have some other symptoms on top of that as well. So
Mm.
general well-being could be remarkably improved. But I mean, I
Mm.
imagine, you get a lot of referrals for chronic fatigue or long COVID, or
Mm.
chronic headaches or anxiety and depression and stuff like that. And I think all those things would respond well to what you're doing. So
Yeah.
if you can nip that in the bud as a GP, you do have a great service, because you don't end up doing a
Mm.
gazillion tests and going down
Yeah.
what they call specialty ping pong, going from one specialist to another. Don't do that. If
Yeah.
if your pattern is right and you've got positive clinical signs, you've got no negative physical signs, and you got and sometimes you might have to do a test and it comes back negative, then you're a strong ground. You're making a positive diagnosis.
When do you think it's not a good idea to refer people to the switch?
People have to be ready to do the work, in my
Yeah.
understanding. Yeah.
Yeah.
So if I mean, you can tell that sometimes how people talk about their illness. This thing happened to me because someone else did something else. That sort of
Mm.
situation can be, you'd have to untangle all that sort of stuff. I
Mm.
mean, you would know the answer better than me, maybe, Well, on that one.
Well, I agree with what you say. People definitely have to be ready and they have to be willing to do the work. Um, and yeah, also, I guess I check out what has your doctor said, like particularly with chronic pain. If they say something like, oh, they've done scans and they can't really see why I'm in so much pain, you go, right, that's a great setting to come to the switch, because they've taken the steps to eliminate some kind of physical situation that does need mainstream intervention.
I, I think just be open to it. If a patient comes back from someone and they got better, I want to know
Mm.
that's great. How did that work? But
Yeah.
so some people will say, well, you mean you got better and their treatment worked and mine didn't. Maybe they feel a bit defensive about it. I don't know. But I mean,
Mm.
it takes a while for populations of doctors to get the new ideas, and these illnesses are completely legitimate and they stand alongside any other illness, like heart disease or
Yeah.
degenerative diseases or cancerous diseases, or
Yeah.
so that's to become normal. The same thing with
Yeah.
COVID coming in a bit, long COVID. um, some people have funny ideas about long COVID, that for whatever reason you contributed to it yourself in some way, but
Mm.
hopefully the long COVID experience helps validate and endorse the chronic fatigue experience. Doesn't matter which
Mm.
trigger it is, if it's a
Yeah.
head injury or an illness, or whatever. I saw a person with chronic fatigue after they developed cancer,
Mm.
which was a real double whammy.
Totally. But it makes
No,
sense though, doesn't it? Because it's terrifying to get a cancer diagnosis. And if your body is way into the stress response like that, then it's going to drain a lot of other organs
oh
and
yeah.
systems in your body.
The way I think about that now is that you've got a pain system, right? And so chronic pain is a disorder of the pain system, but you've also got an energy system or a fatigue system. And fatigue is a very helpful device to give you a rest when your body's tired. So you can just as easily get a disorder of the fatigue system as you can get a disorder of the pain
Yeah.
system. And once you've got that, well, the central nervous system is driving that, and any little trigger can trigger it off. So that's, to me, it's not a mystery anymore. Whereas I first went into clinical practice, I thought I couldn't understand that. You do blood tests and thyroid tests and bloody blah. But no, it's a disorder of the fatigue system, and disorder of the pain system, disorder of the motor system. That's all unconsciously controlled by the central nervous system. So I'm excited by it because they're no longer a mystery, and people can get better, and that's no longer a mystery either. But I wouldn't be necessarily needing the validation of a randomized controlled trial to say that what you're doing is effective. I mean, what you're doing is effective, clearly, and as I say, it's based on modern neuroscience. So carry on doing it, as far as I can see, and you're providing a good service for people around the country. So it's great.
Well, thank you very much. I've really enjoyed our chat. I always enjoy our chats, but there's some really interesting examples that you shared today. So, yeah, thank you so much. I really appreciate it.
Nice to chat.